Hello, and welcome to Beyond the Limb, where we explore physical therapy evidence, expertise, and innovation in limb loss and limb difference care. I'm your host, Will Riddick, and I'm a physical therapist focused on improving care for patients with limb loss and limb difference. In this episode, we're diving into the topic of outcome measure use in limb loss and limb difference rehabilitation. Outcome measures help clinicians quantify progress, guide clinical decision making, and communicate effectively across the interdisciplinary team. They also play a critical role in collaboration with prosthetists, helping inform decisions about prosthetic prescription, alignment, component selection, and readiness for higher level mobility. When used effectively, these tools strengthen communication across the care team and support more patient centered, evidence based care. To help us unpack this topic, my guest today is Dr. Meg Sions, Associate Professor at the University of Delaware. Meg's research interests focused on evaluation and management of chronic health conditions, amongst which includes lower limb amputation. She is the principal investigator of the Delaware Limb Loss Studies Laboratory and serves as the director of the university's interdisciplinary limb loss clinic. She's also an instructor within the Doctor of Physical Therapy program. Meg has also contributed to the development of educational resources to help clinicians better select, administer, and interpret outcome measures in clinical practice. Her work bridges research and clinical care, helping ensure therapists have practical tools to improve outcomes for patients. Meg, thanks for being here.
Yeah, thanks for having me.
To jump right in, I kind of want to hear a little bit about sort of a little bit of your clinical research background and basically kind of how did you come to be in this area of practice and research?
Yeah, I wouldn't say that it was what I set out to do when I started physical therapy school, as many people kind of find on their clinical pathway journey, right? I
What was your
started,
original?
yeah, I wanted to be a pediatric physical therapist.
Oh, okay.
I went to West Virginia University. I thought I would work in like rural healthcare, really treating pediatric patients. And I had a couple of young children under the age of 3 with limb loss and limb difference. And I really liked the orthopedic aspect of that. And so I decided I wanted to do an orthopedic residency. And there weren't any in the state of in the state of West Virginia. So I started looking around and Delaware was close. And so I came to Delaware to do an orthopedic residency in adults, not pediatrics, thinking I would go back, and ended up doing my PhD after that in geriatrics, orthopedics. So, I think you just kind of walk through the doors that like open up as you go through your career and seem interesting to you. And I had finished my PhD work in geriatric low back pain, and one of the prosthetic companies locally had come to us and said, we're having a lot of difficulty getting patients' prosthetic devices covered. Would you be willing to do an interdisciplinary limb loss clinic? We have a physiatrist who's really interested. And I said, yeah, that would be great. I'd love to do that. And we started, it was a very small clinic, seeing a couple patients a month. And we built that up to 10 patients a month over the last 10 years. But what I quickly realized when I went to some conferences that were specific to orthotics and prosthetics is that the research was really lagging behind other areas of clinical practice. And so that kind of opened the window. And I would say it was like the pivotal moment for me where I was like, I really think this could be a fruitful like research career for the long term. And so I still do low back pain research, but I also would say I largely do limb loss research at this point.
That's such an interesting journey to get to there. That's an awesome story. Well, let's kind of get to the topic at hand here. So obviously we're talking about outcome measures, and that's been a key aspect of some of your work and some of your research that you've kind of come out of this. Kind of just real briefly for listeners, I know this is a major topic, a major thing of physical therapy in general, but in your own words, why would you say that outcome measures are important to bring specifically to this patient population?
Yeah, I think this population in particular, it brings a level of objectivity that is really critical, right? With prosthetic prescription, there is a lot of subjectivity that comes with that, right? Just in seeing patients and how they present and trial and error. And I think with that variability comes a lot of clinician variability in how prostheses are prescribed. And so we have, the functional level classification system. And because of this variability in prescription, we can have patients that are at 2 different facilities and one classifies them as K2 and another classifies them as K3. And I think that using outcome measures have the ability to help us to have objective data to help to classify these individuals, which then helps in terms of everybody on the healthcare team saying the same thing. So if we're using a collection of outcome measures and PT is assessing and they're using these measures and they say K3, and O&P is using these measures and they say K3, I think that creates a stronger case for the patient in terms of their prosthetic prescription, and creates, a unified theme, or if you will, that they're not getting discrepant answers depending on what provider they're seeing. And so I think that's a huge value here. The other thing is, I think that, outcome measures in general tend to be very motivating for patients, right? Where they can be compared to their peers and how are they doing compared to somebody else who has had a unilateral, like below knee amputation or a bilateral amputation. But also then they can start to look at the data compared to what would they look like if they didn't have an amputation, or what did they look like before their amputation, and what do they really need to get back to in terms of like gait speed to be able to cross the street and not have to worry from a safety standpoint, right? So I think there's the ability to really be motivating to the patient of like, this is where you're at, but this is the potential that you have based on others that have lost their limbs similarly. And also, if you really want to get back to where you were before, then this is really where we want to shoot for. We may not meet it, but we want to get there as close there as possible.
I can hear your experience in interdisciplinary care in that answer and how you're describing that, especially just that element of collaboration and being able to say like the same story, being able to prove that to the like patient and get that motivation. Absolutely, 100%. It's the same things that at least that I see in practice, and I think we hope to strive for across all the profession. Honestly, when you're thinking of like outcome measures, we'll kind of dive into these a little bit more kind of individually, but when you're thinking of like categorizations of outcome measures, what kind of like key categories come to mind for you?
So I think we have, just in general, like we could split this into self-report versus performance-based, right? So things that the patient fills out, maybe in the waiting room or while you're seeing another patient, versus those that are really capacity driven, like things like gait speed or, a 6-minute walk test. And I think there's value in both of those, because you can have a case where a patient, for example, rates their balance confidence really high based on their activity specific balance confidence score. But then when they actually perform their balance test, they actually don't perform very well. And I think that that's an educational moment to really show the patient that these are some of the things we need to work on. And while you may be confident, you may be overly confident. Or you can have the converse, where you have a patient who's not confident at all, right? And they actually perform really well. And you can say to them, like, actually, I think you're underestimating what you're actually able to do.
Yeah, you're kind of getting to a point. I think there are some times where we can make errors in how we might apply an outcome measure. You kind of mentioned that, that if we were to kind of alluding a little bit to this, if we were to rely just on like a patient reported outcome, that may not give a full picture as compared to maybe pairing that up with some kind of objective sort of measure. Are there any other kind of areas that you say would be like kind of a caution of how to appropriately time it or how to use them?
I think timing is a good point. When we think about self-reported measures, I always like to give them before performance-based measures, so that if I'm evaluating somebody at initial evaluation and then reevaluating them at reassessment, the comparison is relatively similar. Because as I just mentioned, if they perform first and then report, they may report differently based on their performance that they just incurred, right? So I think timing is one thing. I think the other thing is, there was a big push for a while to say, well, these are a set of outcome measures that we could use for everybody. These are like the universal standard tool set, right, for everybody. And I just don't think we can be there, because it's so individualized based on the patient. And when you're selecting outcome measures, the value comes in selecting measures that are important to you as the provider, but also important to the patient. So for example, if the patient is saying, I have a really hard time walking long distances, then I might pick the 6-minute walk test. If they say, I'm having a really difficult time keeping up with my husband while we're walking at the park, I might pick the 10-meter walk test to look at gait speed. If they're having difficulty getting out of a chair, I might pick the 5 times repeated chair rise. And so I really let the patient kind of guide me in terms of what outcome measure I should pick for that particular patient. And so there's that consideration, but there's also the consideration about will this patient perform so well on this outcome measure that I won't be able to use it in the future to document improvement for the patient. And so we see that, for example, with the timed up and go, that patients may score, for example, 8 seconds to start. And so they're not physiologically going to be able to have greater than a 3-second improvement at their repeat assessment. And so if I know the person has a high functional mobility level, or I suspect that based on what they're telling me, I might pick something like the L test, which has a longer course where I might not have that same ceiling effect where they can't get that improvement. Or I might pick completely a different measure that I know doesn't have a floor or ceiling effect, like the 6-minute walk test or functional reach or something like that, depending on what they're telling me.
Yeah, there's a ton of great examples of that, and I especially love the point of making sure that you are selecting a particular measure for your patient. Um, yeah, I think it's easy for many folks to look at some things, maybe like some of the clinical practice guidelines, or if you're looking to like ISPO's Compass documents. These are both kind of uh, tools that have like a core set of outcome measures that they typically recommend. It's not just blanket applying those across everybody, but really selecting it from the toolbox, so to speak. In that same kind of light, I'm kind of curious. We've already mentioned a number of outcome measures that you like to choose, but kind of what's in your toolbox in terms of the outcome measures.
Yeah, I always like to think about this in terms of prosthetic specific versus general outcomes, right? And this goes back to this philosophy of I want to compare them to their peers, but I also want to make sure that I'm not under treating them and that I am comparing them to what would be more equivalent to their pre-morbid or pre-amputation status, right? So like age and sex match norms essentially. And so to do that, you really want a collection of both. I would say from a self-report standpoint, like the prosthetic limb user survey of mobility, the +M is a great measure for evaluating compared to their peers. You can say this is where your percentile rank is compared to your peers. But I will say things like the 6-minute walk test and gait speed through like the 10-meter walk test provide data that gives us norms compared to age and sex match peers that's well established. And also what we should be getting in terms of cardiovascular health, what we should be getting in terms of ability to cross the street. So I do think it's important to have a combination of both. I think if you are evaluating socket comfort, you should be looking at socket comfort scores. The other metric that or outcome measure that we're finding to be quite valuable is just giving them a body diagram where they can fill out all the locations where they're having pain, because we're finding that locations of pain can help in prosthetic prescription in terms of maybe I want to give them something that will take stress off of adjacent joints or the low back to try to mitigate some of those pain complaints. The other reason to give them a pain body diagram to look at pain is because we're finding that multi-site pain is actually a predictor of future falls, at least in individuals who are longer term prosthesis users. So, when we look at fall risk, one of the big factors is have they had a fall in the last 12 months, right? And so we should be asking that. But then it's like, well, what other data points can we have to help predict falls? And I think we have some measures in that just after discharge phase, like early on, that we can use, like in terms of the timed up and go, the 4-square step test, those sorts of things. But we don't have as good a handle on what outcome measures to use a little bit later in the process. So like when they're 1 to 5 years out to really predict future falls.
Yeah, I really like your point about taking this in terms of like prosthetic versus like just kind of like general outcomes and looking at the patient from kind of like a holistic standpoint because um much in the same way that research is challenging in this population, is that this is a highly variable population where you may have some cardiovascular issues. And so some of these more cardiovascular related kind of outcome measures may be highly relevant to the patient, or comorbidities, of course, is also a high comorbid kind of population too. So yeah, 100%. Um, I'm kind of curious also, we were kind of talking about a little bit about how outcome measures can kind of drive the plan of care, about how we're looking at tracking progress. And obviously in the physical therapy profession, we're using uh, outcome measures to help justify reimbursement, to help get more authorized visits, for example, if you're like an outpatient setting. Or even just internally speaking, like demonstrating quality of care in terms of like improving your services within a system. But I'm also wondering, in terms of, one of the things that we see a lot in prosthetics is being able to move on in terms of like moving into a new K level and moving up to different types of componentry. I kind of want to hear your thoughts on the role of how outcome measures work in that process.
We do use outcome measures to track trajectories over time. I think that can be quite valuable, especially if you're doing it in a standardized way. So we use standardized scripts when the patients are coming in. Sometimes it's yearly, sometimes it's every 6 months if they're having a change. But you're absolutely right that you can take that data of how they were functioning in their old prosthetic device or in their current prosthetic device, and you can compare that after a period of acclimation. So like maybe they've been trialing out a new device, for example, for a couple of weeks, then you can bring them in and you can retrial them on that. And I think that is really valuable data. I worry about doing that without an acclimation period because I do think there is like a training that has to occur, like with each new device and its nuances, right? But I think that can be really valuable information. The other thing is, it does show us patients when you're tracking like that maybe need what I'll call maintenance therapy, although it's not really maintenance, right? But like almost like a tune up where, do you take your car in, you get a little bit of tune up. Maybe you have a patient that their balance, for whatever reason, maybe they had a hospitalization, their balance isn't as good as it was. And so you can kind of see that by tracking over time, and you can implement like physical therapy to try to get them back to where they were before. And so we see that in terms of regressions, but we also see that in terms of progression. So maybe they were testing before with a knee that was really more of a K2 knee, and now they're walking at a speed where they need a different microprocessor knee because that knee just can't keep up. And so I think there are ways to use outcome measures to justify prosthetic components, as well as to tell us when we maybe need to do, a bolus of physical therapy to get them back to where they were before.
I like that phrase, a bolus of physical therapy. Yeah, as far as kind of the acclimation period, I kind of want to unpack that a little bit.
Yeah.
I think I have a sense of what you're getting at with that. But kind of what would you say would be representative of like a patient having gone through an acclimation period, or a time where you feel like it would be appropriate? I know this is a very broad question, but
Yeah.
in terms of like, what would that look like, and when may be a sign that, okay, now they may be ready to reassess those outcomes?
Yeah, I've seen changes like with a new device in as little as 2 weeks of like acclimation if the patient picks up things fast and they're using it a lot. But I think this has to do with how frequently the person is using the device and as to how quickly they acclimate and whether they're challenging themselves in ways that would show with that particular outcome measure, right? So this is a really kind of nuanced question in that it's all about kind of like motor learning and like it's all about repetitions. And so if they're not getting sufficient repetitions because they're only use their prosthesis 4 hours a day, that acclimation period is going to be a lot longer than somebody who's using it 12 to 16 hours a day, right? And really kind of testing the limits of it. And so the patients that we've seen really short periods of acclimation where there are giant jumps in their functional improvement with a new device tend to be the patients that are using it like at a high number of hours and really in multiple environments outside the home.
Yeah, that's Couldn't agree more. I would say I have seen the people who in my professional opinion, I would say like a 2 week acclimation. I feel like I've also seen 2 year acclimations with
Yeah.
folks too. So yeah, completely highly variable. So just want to hear your thoughts on that one. As we're talking about kind of the collaboration, the communication that outcome measures are able to bring, in your experience in the kind of the interdisciplinary clinic, um, how has that process gone? How have you used outcome measures to communicate with other providers, be it physiatrist or prosthetist or whoever?
Yeah, I think largely this comes up in our assessments, right? Like people are looking for, especially providers that are very busy, like the physician, they're looking to the assessment in 1 to 2 lines to be able to tell them really what's wrong with the patient. And not just, the physiatrists that we work with, but also like the primary care providers so that they're aware of what's going on. And so I think the ability to say, the patient's performance based on these 3 tests demonstrate they're at a K3 level and really summarize that. And then within the documentation, you have the actual data and you have the data tables to show like this is why they're at what level they're at. They can go and look at the nuanced data if they want, but what they're really looking for is a summary of how you came to that conclusion. No different than like if we were, for example, going to diagnose a probable cervical radiculopathy, we would say that these are the collection of tests that suggest that, right? It's very similar in that respect. And so they're used to seeing that type of language and layout. So I think if you can kind of stick to that, it's very easy for them to understand where you're coming from, regardless of what discipline they're in.
To kind of move into a little bit more practical sense in terms of like kind of starting to utilize these gaining resources and sort of things. Um, I think outcome measures can sometimes be overwhelming, especially if you are in a setting um, maybe that may have not historically used a lot of them. I think there's certainly some resistance to change that can certainly happen. Um, and some of these measures are not necessarily short. Some of these questionnaires or even, for example, the amputee mobility predictor, they can take a little bit of time to kind of get through. Um, do you have kind of like general recommendations, like if you were kind of mentoring somebody in terms of trying to improve the efficiency of outcome measure use within the clinical setting? Um, yeah, I guess the efficiency point there.
Yeah. So, what I've learned in terms of implementing outcome measures in general, regardless of the population, when you're in an outpatient practice, is that you should start with 1 or 2 outcome measures that you think have the most value for the most number of patients. You're not going to do that outcome measure on everybody, but you're going to do it on everybody who's applicable, right? And once clinicians start to understand, like, this is the data I get and this is how I can use the data, then they want more data and they will come to you and say, okay, well, what outcome measures can I use for this, which will be something different, right? And so you get that buy-in piece, which I think is really critical. So I would say you start with 1 or 2 self-report, 1 or 2 performance-based measures, and you don't expect your staff, and I don't remember all of the cut points for like the minimal detectable change and you what is the K level for this and like what are like no, you have a cheat sheet and you administer the outcome measure and on your laptop you pull up your cheat sheet and you say, oh, this is where they fall, and then you document it, right? We can only keep so much information in our brains, and so I think recognizing that this is something we are going to then go look up to see where we're at, is, I think, just acknowledging that is incredibly important, right? Um, and so the other thing I will say is that with performance-based outcome measures, I will generally not do ones that take a long time because I do think it is harder to get buy-in from clinicians who are very busy. But to do the 5 times repeated chair rise or to do gait speed is very quick. And I'm going to do gait anyways because I'm going to be looking at their gait. And immediately after I do that outcome measure or watch them get out of a chair, that's an education moment where I can immediately be implementing functional training. I already have the data. So the next 3 minutes can really be training that individual to do this better. And so I think if you think about outcome measures as being incorporated as opposed to like an extra thing you have to do, it makes it a little bit more tangible, a little bit more palatable, maybe, as clinicians who are really busy.
Yeah, it's actually the setting that I'm in. We have implemented the 5 time sit stand and a 10-meter walk test as kind of like standard measures across the system. And of course, if you have somebody coming in for an orthopedic condition with the shoulder issue, those aren't going to be as applicable. And so they may not go down that route. But for the
Yeah.
majority of the population, we are trying to do those kinds of things. And like you said, it's they're things that we would already be looking at. So we are getting that information from it. Um, as well as being able to get some data that we can then utilize for setting goals, etc. So yeah, 100%. um are you aware of any kind of like kind of, I guess, like digital integration, some of these like computer adaptive tests that have been coming through? As for example, like in our system that I work in, we're starting to implement more promise measures, like promise
Mhm.
29 as a key measure. To kind of almost like doing it even not necessarily within the session, but sent ahead of time. Have you seen that in other ways?
Yeah, I have seen the emergence of that. I think because of the variability in EMR systems, and how well those are integrated in various systems, I think that is the real challenge in terms of universal acceptance. But I do think there is some value to sending stuff ahead and having patients fill it out ahead of time. Although I think we have to be really cognizant of burden, because that is like a critical piece of this, right? And the other thing I think about is I always feel like if you can preface the outcome measure with why you're doing it or giving it to them before you give it to them, it always goes better, especially when you're asking things that you might be screening for, like mental health status. I'm a little bit opposed to like giving patients like depression screening without having some sort of preface of why I need to know this information as a physical therapist, especially like treating a limb loss population, but like really normalizing the whole like depression um, states that occur, right? Like in terms of the grief process after amputation. I don't know that I want to give that to patients in its entirety, other than maybe like a 2 item screen without really having a conversation about that first.
Yeah, that's a great point. Actually, I really love that. Yeah, because it brings some context to them to understand. I'm thinking about the times where I've had to like go through subjective questionnaires, and I feel like patients also have a lot of questions that come about with them too. Um, yeah, absolutely. Um, Again, kind of diving kind of into this practical sense. Obviously, you've contributed quite a bit of educational materials in this area. I think it was a number of years ago. I saw a conference presentation where you showed your website had a number of like these different uh, kind of tools that you've kind of created for different tests. Tell me a little bit about those.
Yeah, so we started that because we had been giving educational sessions and clinicians were saying, well, what are the standardized scripts? And we're like, well, there really aren't any, unfortunately. So we said, okay, well, let's come up with some standardized scripts. Well, where is the data to interpret? Well, we don't really have that either, right? So we pulled the data from the research articles so that you don't have to go and find all of that information. It all lives in one location. So essentially, those are your cheat sheets for administering the outcome measures in terms of performance-based measures, and then also how to interpret them, right? So you have it all in one place. And I think that that is really helpful then, especially if as a clinic, other people might be doing reassessments on your patients, right? Everyone's kind of using the same information in terms of administration, but also in terms of interpretation. And so we have those on our research website for free, so you can access them. The other paper that we did, which we thought was really important, is we did a paper looking at selecting, administering, and interpreting outcome measures that was published, and it's published open access. And it's specifically for clinicians so that they have all that information in an article with like all the nuances of things to consider with regards to performance-based outcome measures.
And we will definitely have those linked in the show notes for folks to be able to check out. Yeah, absolutely. Great resources for sure. I remember another kind of talking about making sure that you have kind of, I guess, inter-rater reliability for for use of these measures. I remember a conference presentation a number of years ago where I think they showed a video and they had everybody in the audience select what the scoring would be for a Berg. It wasn't like it was just one item, not even the whole thing. It was just one item and had everybody select what they thought it would be. And they even had the descriptors from the form of what it would be. And it was rather embarrassing about how it uh unreliable we were as an audience, as a group of physical therapists that were doing this test. So I think anything that we can bring to the forefront, I think is such an incredible help for just the general PT population for sure. Are there any other kind of like outcome measure resources that you would recommend folks who are kind of trying to build this area or maybe bringing in more outcome measure implementation to the clinic? Where would you recommend folks turn to?
Well, I think this is a real struggle, right? I think probably the best places for getting this type of information tend to be educational sessions at like combined sections meeting or like the AAOP or AOPA meetings. They tend to have more outcome-based sessions that are really specific to this population. I think that's probably where you're going to get the best evidence, because it's just simply not practical to go and read all the literature, right? Like that's just not a practical way of attacking this. We have started here at our university to pull in clinicians who are local, who are treating these patients to participate in the curriculum so that they're getting the latest and greatest every year in terms of they're serving as teaching assistants in the class as we bring in patient models for our students to work with. I think if you have the ability to connect with a local university that has a physical therapy program where you can be involved and sit in on lectures, that's a great way to learn like what's up and coming. And also get some like hands-on practice that first year, and then maybe you stay on as a TA for a couple years after that. And we found that that model is quite successful and also trains up our local clinicians so that we have more people to send our patients to who are like in the southern part of the state when it's 2 hours away, right? It's not going to be feasible for them to come to us. And so that's really helped to uptrain within our state as well.
I'm curious, how have y'all initiated that kind of process or that kind of partnership within like community clinicians?
Yeah. So generally speaking, I'll look at like where patients are coming from. So like in the southern part of the state, we were really struggling. And so looking at clinicians that might be alumni of our program who might want to come back, looking at just people that I meet at conferences who are interested in limb loss and they might say, "Oh, I'm working in this place in Maryland." I'm like, "Oh, well, like that's not very far from the university. Would you be interested?" So I think really just networking and making connections and letting people know that that is an option, because we do need PTs, like licensed PTs, to come in and supervise when we're doing these patient model experiences with our students. And so it provides those individuals that we need, but it also allows those individuals to stay connected as a community because they're all coming together, for that class every year and talking amongst themselves. And then they send their patients who are, not local, but have driven a long way just for an evaluation to these other individuals who they know are also trained.
I think it's such a great model and something to certainly could be emulated in many places. I think not even just in this kind of area of practice, but for many things. Yeah, really, really cool. It's kind of a two-part question for this next part here. I'm just curious, do you have a favorite outcome measure? And the second part of this, is there any kind of like outcome measure research work that you're excited about? It's coming up.
Yes. Do I have a favorite outcome measure? I don't know that I have a favorite one, but I think if you talk to my students, they say she always makes me do gait speed. So I think that would be the one that would rise to the top. And just largely because, we have a general sense of like what would be a good gait speed and what happens if you have a disc vascular amputation. And, you know, it's a marker of frailty, which we're finding in some of our research that these individuals are more likely to have frailty markers than other individuals who are older. And so I do think it's a good universal health screening measure in general. So I say that's probably my go-to. But, distance walking is one of the primary complaints these patients have. And I think the 6-minute walk test is really important. I don't always do a 6-minute because sometimes we're finishing up the session and I do it out the door. Literally, I'm like, okay, well, our session's almost over where I'm going to walk you to the door. Right. And so we do the 2-minute walk test out the door, literally. And I think that that's perfectly fine. Right. Especially individuals early on when their functional mobility status is low, I think the 2-minute walk test is a great test. I think if you really want to look at cardiovascular capacity, though, you have to kind of push them to do a 6-minute walk test. But the other thing that the 6-minute walk test will tell us is when do they get pain? A lot of times they'll get a pain onset, and we can figure out when that's occurring. And that can be helpful from a diagnostic standpoint. Also, we're watching their walking over a period of time, and we can see the degradation of their walking. So I can get a lot of information out of that test in particular. So I like that test. I can't remember the second part of your question.
Any kind of upcoming
Oh,
measures or any research that you're aware of that you're excited about in terms of this area?
well, it's not an area that I'm working in, but I think it would be super exciting in terms of prosthetic technology is becoming more apt to be able to collect not just step counts, but I think other metrics in terms of the accelerometers that are in prostheses. And so I've always said it will be really revolutionary when we're able to detect somebody who's had a near fall or has experienced a fall, and we're no longer relying on self-report, but we're actually using data that occurred in real time. I think being able to look at how patients are functioning in their home environments and in their community is critical, and we just don't have good metrics for that yet. And so I think those can be embedded in prostheses. And I think that's really going to be the way of the future. And we may use less in-house clinical outcomes because that really becomes more the norm to look at what they're doing in their everyday environment. So I think that's a really exciting area of research.
Oh yeah, most definitely. Because I have patients who will come in and show me their step counts from their computer or their microprocessor needs to be able to show
Yeah.
that. And yes, I so wish I could tap into some of the torque mechanics of things. And yeah, in terms of near falls, it reminds me of some of the remote monitoring that we see in a cardiac population. So I think that sounds very feasible for probably not to the too distant future. So uh, if anybody's listening, that's a good thesis right there, or a good project to work on. We'll see that happen. So my last question, I always like to kind of bring this back to the patients because this is why we do what we do. As a clinician, I guess as a researcher and clinician, do you have an example, or is there a patient that kind of sticks out in your mind when you think about the power that outcome measures are able to bring?
Well, I think there's several. I think the most probably impactful one early in my career is I had a woman who came in, and she was a brand new prosthetic evaluation and then treatment. And she said, I have a cruise and it's booked in 3 months and I'm going. And I said, okay, that's a great goal. And I was like, oh, let's see how far we can walk today. Right. So we do the 6-minute walk test. We got 50 meters. I'm like, oh, we got a long ways to go here. We got a very short time. Right. But she had a lot of pain. Right. And the thing is, we put her on a graded walking program because we knew there was going to be pain, there was going to be discomfort. But she was like, I am going on this cruise with my husband. It is our anniversary. I am going to go. And she, and some days were better than others, but every 2 weeks, we did the 6-minute walk test, and it slowly, we start to see a nice climb, and she's doing her exercise logs and logging how much she walked each day. And she did. She went on that cruise, and she said she did a couple excursions with her husband, and they had a great anniversary. And I do think because she had pain, seeing those numbers, because the pain didn't change. right? The pain stayed the same. But seeing those numbers climb assured her that she would be able to do this and that she could meet her goal. And so I think that that's where outcome measures can be really quite valuable and motivating.
Yeah, it brings power to what we're doing, and yeah, helps patients meet their goals. That's fantastic. Well, Dr. Meg Sions, thanks for joining us.
Yeah.